Hey sister.
Hey sister.
Hey sister.
Hey guys, welcome to the episode of Hey Sister. I thought before we introduce our guest for today's episode, I'd lighten it up with something that happened to me during the week. So I went away for my brother's 21st and our dog doesn't always get along with other dogs, but there's this friend that we have and their dog and they get along and we were good. So I dropped her off there, they were fine, she sent me videos overnight, they were getting along, everything was good. The next day they started fighting and she was like, I don't think this is going to work, I'm going back to work, we need to figure something out. And our backup plan was my husband's parents were going to bring her home and have her at home. So that's fine, I'd left the keys, they went and got her a bit reluctantly, picked her up, got here and they're like, the key's not working. And they're at our front door, we are somewhere else and they can't get into our house with our dog who is apparently an anxious mess. Anyway, I realised I gave them my grandparents' key to their house instead of my house key. So then I was calling around frantically and they had to drive all the way from our house all the way back down south to drop our dog off at my uncle's house, who hasn't met their dogs before. And so we got thrown into two other dogs, but it was fine and they got along and it was all good. But I got a thank you present for my in-laws because I felt a bit bad with them. Holding a dog up and down.
Doing the run around.
Yeah, so that's my little thing from the week.
Bit hectic. Talking about bit hectic, I'd like to introduce introduce our guest star today, who is the lovely and beautifully talented Chloe. Hey guys. So, as a bit of background, Tennille and I both know Chloe through our nursing careers. I met Chloe prior to that. We went to high school together. And through nursing, we went to uni together. And, Chloe and I share a love of surgical nursing as well. We're both surgical nurses by background. Of course, we've all sort of kept in touch along the way. Outside of her nursing career, Chloe has many interests. She's of course a gym girly, loves a hot girl walk, has a newfound love and passion for Pilates. Chloe is also not shy of a good time. It doesn't take much to twist her rubber arm. She does get a bit of FOMO when she misses out. So yeah, other than that, that's our friend Chloe, and we'll sort of move into the podcast, hey?
Yeah, well, hello and thank you for having me. I'm so excited to be here.
So was nursing what you thought you were going to do when you went to uni? Was that your plan?
Yeah, there's like kind of two things like growing up, I suppose, what I wanted to do. The first one, I think back now and I'm like, no way, that is so not me. So that was originally, I wanted to be an accountant. Yeah, my reasoning for that is I liked math at the time, but as I suppose time went on, got older, and actually really had to think about it, I just didn't want a sedentary job. I liked the idea of work-life balance, being like shift work, days off during the week. Yeah, talking to people, not sitting at a desk pretty much. So that kind of led me to nursing, as well as like family member in there, and just like listening to stories at the dinner table, you know, like, oh yeah, like funny stories, you know, or just like experiences, like how her day went. Yeah, also kind of inspired me, I guess, and I've always looked up to my auntie, so yeah, that's where that kind of stemmed from.
So that's obviously where your passion started. Tell us about your early nursing career, transitioning from student life into, say, grad year, and what that looked like and how that felt.
Yeah, so I was so glad uni over and done with. Going straight from school, having a bit of pressure on me through school to get good grades, despite my parents not even finishing. How's that? I mean, whatever, that's fine. Grade 10 certificate counts, right? Yeah, a bit of pressure growing up. So going into uni to do well, I was like over it. Like, so when uni finished, I was like, that was like the biggest relief off my shoulders, which yeah, was so nice. And to be honest, I didn't really love uni, more like I didn't really like the theory side. Again, simulations and OSCEs and things like that, I still don't like. I just don't like the simulation. That's flat out hate it.
Is it the pressure of having people
Just
watching?
awkwardness. I'd rather practice on a real patient,
Yeah.
like the real life scenario, like it is it is what it is. Yeah, I just can't talk to someone who's not going to reply to me. So, but I can talk to other people, you know, like kind of talk them underwater. So yeah, really after uni was I really liked the practical. With going like doing placements and things, and I never actually did a medical placement. I definitely had a passion for surgical. And one of my last placements was on a surgical ward that I got a grad position on, and I am still there to this day, 5.5 years later.
And I'm sure that has changed from your grad year and your role and what you thought nursing was to now what your role is. I assume probably being a bit more of a leadership position, educating new starters and grads there and students, and a bit more management on the ward side of things then.
Yeah, look, I don't know that I like the leadership side. I don't know if I definitely don't like conflict. So being like in CN positions and things, I don't really put my foot forward for those. So yeah, leadership is not really my forte. Like I think I could be a good leader, but I'm just not interested in it. Just I don't like conflict and like criticism, and I definitely know, that is prevalent in the nursing world. I feel like everywhere, but I'm just not there for it. I prefer like the direct patient sort of contact. So in saying that, like I haven't like applied for CN role or team leading CN roles. I've put my foot forward in like nurse navigating, so a little bit more like leadership in a way, but yeah, more patient orientated versus management numbing sort of vibe for that.
You've certainly been a leader in your ward, maybe not in like a formal position, but certainly with leadership of students, and as you said, you were supporting and pioneering a new discharge program around that nurse navigating. So whilst you might not have those managerial appetites, certainly you've got those leadership skills from what I've heard and from what I've observed. How have you enjoyed sort of stepping into those different roles, nurse navi, and what that's I suppose looked like from a career perspective, but then also home life? I imagine that you're doing some 9 to 5 sort of stuff as well.
I do enjoy like backfilling like nurse navigator and things like that. I am confident in like raising my voice, not afraid to like speak up. I believe I developed like good rapport with whether it's like staff, patients, etc. So like that aspect I like. In terms of 9 to 5, again, like Monday, like it's hard. It's like two ends of the spectrum. Like you really want to be at home, do your normal like daily life with your partner who works like a normal 9 to 5 job as well, but also having a day off during the week is also like amazing. Like you can get your life admin done, go for a walk, relax without it being busy on the weekends. And having more than one or 2 days off, like a Saturday and Sunday off, is also great. Like I love a 3 or 4 day break. So yeah, they both come with their pros and cons, but
So exciting opportunity, the couple of jobs that you've backfilled. I don't imagine that obviously everyone would be selected for those roles. How did they come about? How did you get the confidence to apply for them? What did that process look like? I suppose for any of our sisters online listening, wanting a bit of a change, or just wanting to upskill, learn something new, how did that look?
With the discharge nurse role, so it's a bit like of a patient flow role, kind of supporting them like discharge planning, I suppose. Like usually, because the ward I work on is very high turnover, you could have up to 18 patients go home in one day. It's quite difficult to like preempt for the next day. Like people with wound care, you're getting the supplies, asking like who's going to do it for you, can I help you organise that, and then applying for it. It was kind of just, we're trying to facilitate and create flow throughout not just the ward but the hospital. because you have ED calling, hey, we've got a patient, are you ready to pick them up? And when you're flat chat trying to do your patient care safely and just not be able to like tick the task off, you want to care for them like for holistically. So to alleviate the pressure from the primary nurse, this role was kind of developed from the NUM at the time, and so applying for that, it was quite basic and straightforward to start with. I think it was like just a resume and a cover letter potentially, and just showing interest. And I believe most people first got it because it was like the implementation sort of phase. Originally, I didn't actually apply when they first put it out, and then I sort of started seeing what it was about. Like you kind of come off the floor with the heavy acuity, and I was like, oh, I'll give it a go, see what it's like. So then I was like, oh, if you need someone, if no one's available to do it, I can put my hand up. I'm happy to try it out. So that's kind of fell into that. It is 12 monthly EOI sort of thing. And each year it's kind of been different. A few years it's been like just your CV and a cover letter. Otherwise it has transitioned to like a PowerPoint and explaining kind of the role. That's really about it. It's very basic. It's just internal to the ward. So very like low expectation. I feel like being like kind of not successful in getting roles, just being like honest and reliable and sort of things like that will get you a long way. So I just think that's like a tip. If you don't know, just ask. It's patient safety at the end of the day. However, in regards to the nurse navigating sort of role, I had seen a few other more experienced nurses who are like more CN roles, I suppose, apply, and I was like, oh, that's also like a really good, sort of opportunity. So then fortunately for me, one went on maternity leave, one went to ICU, and then I was kind of like just interested. So I did approach them. I said, oh, I'd be like keen to work with you one day. And then someone needed to backfill and there was no one, so then another EOI went out and just applied for that. Luckily as well, no interview. Go me. Just sliding in the slot. Had a few training days, so that was good. Like you felt a bit more comfortable, like knowing the role, and it's completely different. Learning the role with like the education or follow me around sort of days was very helpful. And then kind of just that went on for 12 months and then reapplied. And
So for people who don't know, what is a nurse nav? How's it different to a CN? How's it different to education or NUM? Or what's that role kind of look like?
So a nurse navigator, I think in this situation they have paired it with a CNC. Different to a CN, I think you just have a bit more responsibilities. And it is funded, so you're booking your own appointments and making it you have to develop your own funding, I suppose.
I imagine with that it'd be quite autonomous work, so a clinical nurse would typically work underneath the direction of a nurse manager, whereas
definitely.
I imagine it'd be, you sort of lead your own day or lead your own caseload.
Yeah, that's exactly right. So the autonomy is nice, but it's also when you haven't done something like that before, you're kind of like, oh,
what do I do today?
What am I actually at? But again, kind of working very a lot closer with the doctors, because you're seeing people in this one particularly. It's a lot of surveillance. You're attending an MDT. You're doing pre-op education, and with the pre-op education, there's about the surgery and what it will look like for your journey. The people who are coming in for surveillance, just follow up, seeing how they're going. They're still managing eating and drinking. And
when you say surveillance, that's around post-cancer resections and monitoring for recurrence of cancer?
And with the cancer patients that I do deal with, the recurrence rate is quite high, and so the outpatient appointments are quite regular, roughly 2 to 3 monthly. And then as well, this nurse navigator role, she obviously gives the direct contact to her phone, so she carries her phone around, and if there's any questions, concerns, you need some help, etc., something, a lot of people do contact that phone, and that is like you're with someone like coming to you with an issue, like that phone doesn't stop. So then you're like back to the doctors or back to, you know, wherever it is, or this patient can't make it today. You consult the doctor. When do you want to see them next, sort of thing. So
Yeah, the nurse navs I've known patients have their mobile, and they are contactable kind of whenever the patient needs
24/7. Although their mobile is it is just left at work. It is only the time that she works, like Monday to Friday, which is, I suppose, a good thing, not taking it home. That's one thing that as nurses, just leave it at the door. But yeah, 9 to 5 is at the phone 24/7. Well, that's like, it's the personal number, but for the work phone, so which is a good thing.
That role looks after cancer patients. So you're on the surgical ward, not the oncology ward, but these are our surgical patients that will come into you afterwards?
Yeah, so on the ward that I work on, we are like, just depends on the type of cancer they have. Sometimes it's like pre-radiation, pre-chemo if required, like if they need that treatment. Or usually it's they found cancer, they need to cut it out ASAP. MDT turnaround is roughly a week to 2 weeks, depending severity.
Sounds like quite an interesting role, especially from my previous surgery experience on the wards. If you're a surgical nurse, you kind of do see the patient just there and then. You're of course aware of the fact that they have MDTs and that they do engage with service previously, and then of course you expect that there's some level of follow-up, but really you are just pigeonholed into that one area of, all right, surgery, you come in, you have your operation, you know, you eat, drink, pain-free, fart, and you're out. Like, that's it. Patients are ready to rumble, and then they're gone. And that's sort of all that you see of that patient journey. So I imagine this role has probably enhanced your general sort of surgical day-to-day role, because you've got extra context and you know how to educate your patient and allay any concerns for the next steps as well.
So true. It's very like tunnel vision on their current state. And that nurse, the navigator role, you see like, oh, you're back to doing your hobbies, or like, are you interested in these sort of things, or, you know, what are you up to? You're going on holiday and things like that. So that's really nice, and I do really like the continuity of like care, because I feel like I'm a very compassionate and empathetic person. Can switch off, but those sorts of things, like I do get invested. It's sad when they're going through, and some like the procedures that they do go through. There's, I don't think you see me signing up for that. Like it is huge, and the quality of life afterwards, for the surveillance period of roughly 5 years, is very taxing and tolling on not just themselves, but their family. Like they rely on their family a lot.
You can look at it from two ways. It's obviously a very taxing role, but equally what a privilege that you have to be able to be that support person for people going through these times. And I can only imagine how important it would be to have someone who is compassionate and who is genuinely invested, as you say, in their journey. So I think it's some pretty important work that you've been able to engage in. I'm interested to touch on a bit more about that compassionate side. That's a bit of a reason why I left the more clinical space and transitioned to the more corporate nursing, because I'm very passionate, or far too compassionate, about that really holistic patient-centred care, and took a bit of that home with me a little bit too much. So very keen to hear how you are able to switch off from that, or just sort of compartmentalise that.
So compassionate and switching off, like, I don't know, I don't have anything particular, like no tips or tricks to give. I don't know, I just can. I mean, I sit like sometimes silent on the way home from a shift, just driving, and then I'm somehow home. Like I do like not reflect, but also like I do think about it. But once I'm home, it kind of like,
that happened, and I did my best. And they're doing their best and out of control.
Like, don't get me wrong, I definitely go, oh my god, that was a terrible day, or like, it was a good day, but it kind of just leaves it at that. It's also, I don't know if you find the same, like, my partner's not health literate at all, so talking about it, he's kind of like, what's the point of explaining sometimes?
Yeah.
Because I'm like, okay, this is just wasted, and then I'm just still talking about it.
And some really good tips, I suppose, to take home is just that, again, thinking about what's the value in continuing. I'm interested to hear your take, Tennille. You're obviously working in emergency department, so you'd be, I believe you'd be seeing some pretty traumatic things.
Yeah.
How do you do that switch off and really
Yeah.
back in your compassion?
You definitely see stuff. I think I've seen less than other people just simply because I haven't been on those shifts. Some of our really traumatic days, I guess you could say, I have missed, and you can see the impact it takes on the whole team, and debriefs are really big in our department. Straight away happens as soon as that patient has either gone to ICU or like whatever's happened, it's almost immediate, just to get all those things off your chest with what went well and what did, just talking about it, because you don't know what you're going to get through the door each day.
Are they structured? When you have a debrief, is there like a debrief leader? And
Usually it's the medical lead, just because they generally they've led the resus as well. So they've led the resus, so when you come into the debrief, they're generally then leading that and leading the discussion and how that discussion looks.
Do you find it's then quite a clinical debrief? And that might be valuable in the sense that you can go, oh, we couldn't do much more, but just...
It can be, not always, and I think that's because you have medical and nursing there. So no, because you're not ticking boxes, you're just generally discussing it, and conversation will just kind of bounce back and forth. It does depend on your medical lead and how they like to structure it. And that will change it. Personally, I'm really good at being able to switch off. I think the only time I was really attached to a patient and their story, and it was when I was on a peds ward, the patient was just similar to my brother. So that's why it hit home, more so than his condition or what happened to him wasn't necessarily like crazy different to anyone else, or worse or better or any of that. But as soon as you make small connections personally, I feel like that's when things are harder. It's not the patient, because, you know, ED, you have people that you can't save. You have people that go to theatre and you actually don't know what happens. People that go to ICU, people who are reoccurring and you see them every day. And so I think if you held on to every single patient, you wouldn't be able to do it. You just, so I literally couldn't tell you what I did on my last shift.
Wow.
As soon as I leave, I don't know what I did that day.
See, I'm built different. I can still recall the UR numbers of 2 of my long stay patients, and I can tell you their full names, and like I was
Okay, well.
I might be able to tell you a first name, but it'd be like, you know, the patient that was in that corner room.
I'm very
I'm
descriptive
too
like that. Like I
invested.
can tell the room, but not those specifics. Wow.
Yeah, I think I'm too invested. Like, don't get me wrong, there's definitely some patients that would be a quick in and out sort of thing, but like working on sort of a trauma and a bigger, like a quite a complex ward where we'd have patients that would stay, length of stay on average I think was like 12 days or so.
Oh,
So
wow.
that's quite a long time. You're going from like your quick ED visits versus like 12-day stays. I feel like you definitely start to build rapport, and this way that we would skill mix and allocate nursing allocations for the day would be usually you'd stick with the same patients just for that continuity. You begin to see like what's their baseline, are they improving, are they not, and it's really good from that patient safety perspective and also from that person-centered care that you're building that rapport. But it does mean that you do, on the opposite end of the spectrum, get a bit too invested or really, I had this one patient who, she again reminded me of my grandmother so much. And she was on our unit for so long, and she had maybe 2 or 3 admissions, and then I had seen her again just through a different role that I had in the hospital, and just seeing her family family and seeing her daughter, and I had I just felt like they were my family, and I just remember getting there, like seeing them and just crying, like, I've missed you, but I don't know these people. Yeah, so there's emergency nurses and then there's wackos like me who just cannot switch off and genuinely too invested. So I think I spent a lot of my time not caring so much about the clinical skill because I felt quite confident in my clinical skill and my ability to escalate if I didn't have the skill. But I spent most of my time just like trying to figure out how am I going to go home after this. And
Am I going to sleep tonight?
Oh, and then my handovers, you can tell because people will be rolling their eyes like, Cheyenne, I don't give a shit if she likes Cocoa Pops and that her dog's name is Missy. Like, move it along. This is really important to Neil's patient-centered care that we talk to her about her animals. It really peps her up. No one cares.
Yeah, me on the end of the station getting handover. Okay, I've had this patient 3 days in a row. Any changes? Any changes? Expire out the window.
So anyone taking a handover from me, not a vibe. Not a vibe. I'll be the first one to say it. I hate getting handover from me.
Oh, and there's some aspects I kind of like start talking for them because I'm like, I know, just detail, like short and sweet, short and sweet, please.
Yeah.
I can try and read like between the lines.
Yeah, definitely. Yeah, there is that hard balance. I think you kind of touched on it before, Chloe, around not just doing your tick boxing, but definitely still getting that like your patient-centered elements. And I know for me, in particular, working on a really busy ward, what we learnt at uni around patient-centered care, we were part of the cohort of students that had quite a big focus on patient-centered care in the curriculum. I know it wasn't something that was previously taught. So for me, we learned all this stuff about psychosocial development and just, literally just how psychosocial health impacts your physical health. And then we get to actually implementing practice, and I remember some days thinking, I can't even wash someone's hair. Like, it's something that's such a basic need, let alone, you know, when you shower in someone, you get to know them a bit and you have conversations, but it's those little things that is the extra mile, like washing your hair and those bits and pieces. And I remember feeling such a conflict with what we had learned and what we could implement. I wonder if you have any strategies, or if there's maybe you've noticed a similar progression, and keen to hear your thoughts.
It's interesting that you remember all the things you did at uni and how it's not relatable, because I could not tell you a thing I learned at uni. So I think that might come back to that little personality trait we were talking about just before. Obviously you paid a lot of attention at uni. And I'm like, oh yeah, it sucks that I can't wash their hair, but hopefully they'll go home tomorrow.
Yeah, I think in an emergency there would be definitely a fair bit of a step away from that psychosocial aspect. Certainly I'm sure you get your social admits and sort of respite admissions. I'm sure that there needs to be aspects of patient-centered care within that, and certainly when you're looking at consenting and those sorts of things. But I do imagine most of the time this is a machine in front of me and I'm a mechanic and I need to just fix this.
And I think that is what people think ED is, and there are sections of ED like that. But when I was in pool, I remember being really scared to go to ED.
Yeah.
And someone said to me, you know, half the patients aren't even sick enough to get to a ward.
Yeah.
And half those patients aren't. And so really, you come in and you have a chat to them, but nursing-wise, you might actually not do anything.
ECGs, bloods.
But you might not do an ECG and you might not do bloods.
Yeah.
Like this person's come in with a sore ankle. They might just be doing x-ray, which isn't you. Medical has to organise it. You do a set of OBS because you want a baseline set. They might see exactly. Yeah. They might be seen by the end, like nurse practitioner, and you might actually not do anything.
Yeah.
So I think everyone has this idea of ED. It's going to be all traumas. It's going to be all your big stuff. But half of them, it's not like that at all, like in any way.
Fair point.
Yeah.
And I suppose as well, even when you do get your traumas and whatnot, if you're new to the area, it takes quite a long time to become resus trained.
Yeah,
So to
yeah.
be able to attend a resus and be in that room,
You might not even know one's in there because you're at the other end of the
Yeah.
department.
yeah,
Like,
that's so fair.
you know, I'm in a big department. Other places, there's 2 nurses for 8 beds in the whole ED, and you are everything.
Mm.
Ours is a really big department, so you don't know what's happening on the other end at all. Yeah.
Mm. With your nurse navi sort of roles, Tennille just sort of touched on it. Did you go to emergency or other areas of the hospital and see what other areas?
Yeah, so they were a surgical patient. We went to MDT, had surgery, was discharged. Now his length of stay was quite a while, and there were concerns going home, but you can only hope someone thrives in their own environment versus the other way. There were not attending outpatient appointments, and you're like, okay, look, this is a bit concerning. The friend calls and saying, hey, like, this is happening, should I bring him? And we're like, yeah, bring him in. And when we rocked up to ED, lucky he was still pink and diffused and breathing.
It was not in a good state.
No, just but again, lack of health literacy, lack of like self-care, you know, like looking after yourself. Just yeah,
it's a pretty big topic and pretty big area at the moment. Well, it has been for quite some time, around health literacy and how we engage and educate our patients. I think just from speaking in my own experience, seeing the rise of social media, our patients have access to so much more information and expectations. However, it's not paired with a true health literacy. Like, they don't genuinely understand how things link together and what the ramifications are, what actual practice looks like and why that's feasible and this option's not. And
Dr. Google.
yeah,
That's a big one.
exactly. Or the opposite end of the spectrum, where they think, oh, Google says it'll be all right, and they don't appreciate some of the smaller warning signs as well. So
or even getting turned away from your GP. They're saying, no, you're fine, it's just an infection. We get them in to get them into ED, and it's sorry, you've got stage 4 cancer. And you're like, okay, but the last 12 months I've just got told I've got an infection. Or you're fine, you'll be
So I'm interested to know through your roles, all of your roles, I imagine there'd be a pretty big patient education and engagement advocacy components. As I say, it's something that's sort of definitely on the rise. It's a lot more topical. There's national standards around partnering with consumers and what that looks like. We have things up in the media all the time around, usually it's not clinical incidents, it's just that we haven't been communicated with clearly enough. But what's your experience with educating and communicating? How does that look from an advocate perspective? Tell us.
The education side of things, it's just like sort of like focusing on like, if you don't do this, this will happen, or this will, you know, be the consequence of that. And just like really reiterating like why we're doing what we're doing, and like the consequences. I feel like people kind of just brush it off, like oh it'll be alright, leave a dressing like a few more days than it needs to be, but that could be the make or break between getting something amputated, you're going septic, like that. There's a fine line, and people need to know that, like, of the severity. I think
so working on a busy unit, how does that actually fit into, you said before, you're very focused on just how do we get this patient in and out, how do we make sure that they're not getting backlogged in ED. How do you fit that into your busy schedule? Is it, while I'm here wiping your bum, can I tell you about preventing VTE? Like, what does it look like?
It's definitely during the care. I mean, being on the floor as a primary nurse, try to implement it in everything that you're doing, every task, like providing you medication. Okay, this is what this medication's for. I have found in my experience, people are like, they don't even know what tablets they're having. But that's just because people, here's your medication.
Here's your Webster pack.
And it, like the Webster pack they probably don't know about, but the stuff that we implement in hospital, like as you know, like you walk in the hospital doors and you're like 90 to 100% more risk at VTE, and people are like, why am I getting an injection every twice a day or something? You know, just like educating on what they're having, why putting TED stockings on, like why they're so important, or okay, you've got an irregular rhythm in your heart, we're going to do an ECG. If we don't fix this, like, you know, just the repercussions. I don't know. That's just one thing in my practice I definitely do. I don't know about others. I can't speak for them. I know everyone's different. But I like my patients to have a voice, and I do advocate you can say no if you don't want this, but
that'd be pretty awkward. I know certainly in some experiences that I've had before, having to stop a doctor mid-sentence and say, excuse me, that's probably not appropriate language. Can we just confirm, patient, do you know what's going on? So and that's really hard to do, especially if you're working with the doctors frequently, and there is, you know, there's a level of rapport, and you don't want to, you know, bring their name into disrepute in front of a patient, but there is that advocacy, the importance of that. I know sometimes I've waited to the doctor's left and said, what do you think we were just talking about? Would you like me to call them back this afternoon about anything? But yeah, it's a hard role to do. Have you had experiences where it's been quite difficult, or you've had to really put your big girl pants on and advocate?
I kind of, so in regards to that, the patient, there's some really, really great doctors that do such a great job, and even if you went to them at some point in the day, hey, can you come and talk to them, or can you come and talk to their family, they want to know what's going on at the update. Some are great and some are like, yeah, we'll get to it when we get to it, or again, come in medical jargon that they don't understand. Ward rounds, they're like all talking to each other, and then you're going, oh, what did the doctor say? Oh, I don't know. And you're like, okay, well, that's great. So then you have to try and find out what's going on, and just give your best sort of layman's terms to keep them, you know. I don't always say, hey, to the doctor, can you come back? Because I know like they are busy as well, but I know that for the patient's sake, and
it's so valuable.
If they don't know.
And I think sometimes doctors find it confusing when we're like running around, following around, but it's for that reason. So we actually know what the patient's care is, what are my roles today, what are my priorities, and how can I support this patient to even understand what their treatment is.
I think the positive takeaway is that certainly it's getting a lot more attention about the importance of consumer involvement in their care, but equally we know that it was implemented in our curriculum, and I believe it's being implemented now into medical curriculum as well, and I think that that's such an important aspect, because we do get caught up in our medical jargon, and equally the many competing priorities that our medical officers have as well. So it's exciting to think about what the future might hold in that space, and to think about how we might be advocating for patients in 10 years' time and what that might look like. So Chloe, I'm really eager to hear a bit more about your sort of post-grad study, that you've been on this journey of doing some extracurricular sort of study outside of work, well, inside of work but outside of work. Keen to hear more about that, what the opportunity was, how it came about, and what your experience has been.
Postgrad studies, obviously these days it's harder to get further or like positions with minimal or no further qualifications than your just standard bachelor's. Obviously back in the day you have your bachelor's and you became a permanent CN within a year. Well, that's not the case these days. Obviously it's very like lots of nurses and things like that, but yeah, so I had a professional development meeting with my clinical facilitator, and obviously professional development goes hand in hand with like further study, and she was like, oh yeah, like when I did mine, I did an acute transition program through work, and I was like, oh okay, like what is that about? So 2 credit points towards postgrad, and I was like, oh okay, like that's cool, it's through work, it's free, half the money of going back to uni, a bit more relaxed. So I was like, yeah, okay, like I need to do something. But like I said at the start, I was like, I am finished with uni. Like I'm sick of the theory. It's just the pressure. I don't enjoy it, and I feel like I just put so much pressure on myself to do well.
You enjoy learning, but not in that.
I feel like learning. I like to learn it and then teach it to, like, that's how also I learn, is by then teaching other people. Definitely not a read a book and retain it, like one of my friends over here. But yeah, that's just not me. So I have surprised myself, you know, with how much I know, and then teaching people. But yeah, back to the transition program. So that is just finished, thank the Lord, because I got an extension for the last assignment, and here I am sending Cheyenne snippets of my assignment saying, hey, does this sound all right? And I had a FaceTime with them as well saying, am I on the right track? Because I just don't think this is it. And I just was over it. So I'm glad that's all submitted and things. Still waiting for like marks and stuff, but it was a much more relaxed sort of process than going back to uni.
What did it involve? What was yours?
So yeah, you have to go through.
I've done an ED one.
This
I
was.
thought you did the PEDS one.
So I've done the transition program through to ED. So I have 2 credit points for crit care or ED as well.
Oh, so you've got your pediatrics
My
post-grad.
grad cert.
Yeah.
And
And
then
then
I've
you
got now
have
2
plus 2.
subjects that I can go towards
Oh.
a master's as well if you want to do a master's.
Yeah.
Because I haven't continued on with my 2 subjects yet because I don't need another grad cert.
Yeah.
Yeah.
Ah, there you go.
So
I
it's
didn't
just
know
sitting
that.
there.
Yeah. Ours was I think like 6 or 7 modules. It was just like your head to toe, like all your systems. So yeah, the modules, we did have a bit of a training day to go through them, but they weren't technically marked even. And then we had a first assignment that was a reflective essay, and then we also had 2 clinical assessments, like they were called CPATs, and they followed you around. And yeah, obviously had to tick off a range of different things.
Was it like an OSCE? Was it bringing back some trauma?
No, they literally just followed us around, just doing the patient care. Yeah.
Like you said, you prefer a real patient.
Yeah, so nice. And then just a second assignment, which is a case study. So, and actually another range of modules, but they were like special, like you could choose the modules.
Yeah. During modules, there's nothing to prove that you've done the modules.
Yeah, and it was like a work booklet.
Yeah, it was. I found it interesting too. It was very different to uni in the sense that you've got 2 assignment assessments and 2 clinical assessments, and that was really it.
Yeah. I found it a lot easier though than uni, because you work day to day in like the vault, so the knowledge just comes flying out. So you almost forget to relate back to literature because the policy and like it could be like maybe 2012 that hasn't been reviewed yet, but you need more than like less than 5 years old articles, and you're like, but I follow this policy.
So different to my postgrad.
Yeah. What did you do it in again?
Infection control. So it was very clinical based, and
Was that just through a uni?
yes, that was
What's
through
workplace?
No, not through workplace. I don't think they offer any through workplace. Infection control is it's a small community, but it's a big community. They're very well connected with each other. It was something that never experienced it before, and it was quite a nice experience. There is a very strong, tight-knit community. You tend to know who the infection control practitioners are at each of the sites. I think in Australia there's only 80 accredited practitioners. So
Are you accredited?
Yeah.
No.
So there is certainly a lot more than 80 infection control practitioners, just not all of them are either accredited. There are a lot that are very skilled and should be accredited because they should be recognised.
Is that just a postgrad?
No. So you do your postgrad, and then there's different levels of credentialing. So you've got sort of like your beginners, your advanced, and then expert as well. So it depends on sort of, I think it's like 1 year of practice, 3 years of practice, and then maybe 5 to 10 years of practice for your expert, and then it's involved around, so you can do postgrad, or they have like a little foundations course that you do through the college, which is probably similar to, you do get credit points, and with that you also have to do some sort of evidence, like you have to provide evidence that you're contributing to the community and what your action plans are and that sort of thing. So it's a little bit more than just having your degree and your formal, I suppose, education, but it's more so about what are you actively contributing to the community. Very active college that they have. It's phenomenal if you're looking at getting into infection control, or you are in infection control, or whatever it might be. They're very tight-knit community and very willing to share their learnings, and it's something that I found super helpful and just nice to know that, you know, my previous team, there was maybe 10 or 12 of us, and then my team before that there was maybe only 8 of us, so quite small teams that you're working in, whereas my surgical team I'd worked in previous had about 50 staff, so quite small teams, but nice to link in with other areas. But yeah, certainly the post-grad certificate is intense in the sense that a lot of microbiology and that science-based background in with a lot of governance, so obviously standard 3 is pretty important. That was like the start of infection control. I don't know if this happens at your hospital, but the hospital that I did my grad at, you get allocated to a standard, and that's like you have to work with the clinical nurses and develop, you know, sort of action plans throughout the year, and mine was infection control. And I remember the first year that I started, I was like, oh, I think there was still 10 when we started, and I really wanted like pressure injuries or falls because it was real specific, and I thought like, yeah, make a change. And then it became comprehensive care and all was included, and I thought, yeah, that's what I want to do. But I was just allocated infection control, and I thought, oh, boring, I didn't know enough about it. But then when I started, I was like, post-op wounds, hello, hand hygiene, hello, aseptic technique, yes. Like, you kind of started to realise that, yeah, it's pretty relevant on a surgical unit especially. But yeah, were you guys allocated to portfolios?
So, because I was on pool for so long, I wasn't. But when I came to ED, I am.
Also was allocated as well.
It's definitely part of the CN role.
Yeah.
They have to produce the stuff. So unless they're really pulling the like RNs,
I don't know about
you're not
your
really
like most active one is infection control.
Yeah.
And that's just trying to figure out a roster of who's going to do the hand hygiene audit.
Yeah.
And the other one is the blood standard.
I think the positive thing in the background is while it's a shame that you don't get time to do it.
Yeah.
I know in my previous surgical role, the clinical nurses were allocated, I think, some admin time or something to have a look and discuss some projects that they'd like to look at. I know it's really hard to get things off the ground because of time
And I
on the
think
unit.
getting off the ground is so hard. Like
Yeah.
the approval.
Now working in a governance role though, I've seen how projects do get off the ground, and it's usually because they're led by someone whose role is I'm the clinical nurse consultant for infection control, and they lead programs and projects. A previous role that I did a quality improvement, 3 surgical and 3 medical wards around PIVC management, and we had champions from each of the units who were either the standard 3 lead, or they were very passionate about cannulas, or they really wanted to upskill and learn about quality improvement. So we had champions from each of the units who weren't responsible for leading the whole project and the logistics of what that looks like, and collating data and collating research and the difficult time consuming bits in the background that aren't the parts where you see the impact in front of you. Whereas what they got to do is share the message, talk about it. If they had time, collect some data and that side of things. They got to help run some workshops and got allocated, you know, just like a 30-minute allocation in the in-service calendar. So there was ways that we could implement quality improvement and look at achieving some of the goals within those standards without taking too much time away from the wards, but certainly is reliable on those more governance roles that have administrative time set aside for quality improvement.
and it's people like you that have an interest in that area and interest in actually like going into a role where you are progressing that.
Yeah, I think it is. It's hard when you're selling a project, or previous infection control roles, you're seen as the police, and so how you embed that team into the unit so that you're not seen as like this compliance officer, but more seen as like, we really want to help you to achieve your goals on the unit. I know that you've got some standard 3 leads and you don't get time to do your projects. What project are you interested in? How can I help you get it off the ground? Can I do some stuff in the background to assist you? And in my experience, that's the project that actually bloody works, not the project that, you know, I see increase in PIVC issues, you know, infections or whatever it might be. And so I implement a quality improvement. No, you need to have the board suggest this is what we
What
want.
they know
So-
is going to work for their area
Yeah.
or what they're interested in.
Yeah, and I've definitely learnt that the hard way. I know people tell you, oh, this is how you do quality improvement. It's not until you actually do it, and then you go, that's what they meant. That's where I should have actually involved them in the planning a bit more or whatever. So you live and you learn.
So did you think where you are now is what you thought nursing was going to be?
Look, I didn't really have much of a career, not a goal. Like I didn't know where I was going to go. I didn't have like, this is where I want to be, because I do enjoy like the ward, but I do need a change for like own personal like burnout. I'm sure a lot of people experience that. But I've kind of gone through my head of, hey, okay, look at what's the options. I'm not interested really, like I'm not interested in ED, I'm not interested in ICU. I thought about perioperative anaesthetics, but again, change is scary, so that's probably one of those like
A big jump for me.
yeah, and just like putting yourself out there. So it's just like the risk and all that sort of stuff, going somewhere where you don't know everything, and that for me is a little bit daunting. Like I'm proud of like my skills and knowledge and stuff of where I work. So yeah, starting from the bottom again is a little bit
A
daunting.
bit humbling.
Yeah,
somewhere.
and it also comes with a team that you are going to go into, and the culture there. I know when pool staff come to our ward, I try and like, hey, can like talk to them like then a member, not just like shun them, because I would hate for that. I would hate to be on the opposite end and feel like that.
You definitely, there are wards that invite you in and there are wards that don't.
Yeah.
Yeah, and like when I did my grad year on pool, I was mainly surgical, so those wards knew me well, and you know, some of them would have like a picture up on their, you know, the whiteboard of allocations, and they took a picture of me and put me on there because they knew that I was coming often. So there's those little things that does make a huge difference to like pool nurses, and being like, hey, have you worked here before? Do you know where the storeroom is? Because you know, like you're walking around bloody circles trying to look for a dressing, but it's not in that one, it's in that one down the end, and it's
like what are your like vital sign times? Like what time of day do you do
yes,
this?
because they're all different.
Yeah.
And it's so silly.
To Neil, it's 9 a.m. Why are your showers not done?
Yeah, because I have obs at 8. No, we do them at 10.
Oh, where's my time? Yeah, so that's all. Yeah, been a big kind of probably self-limiting factor. As time has gone on, I don't want to do shift work forever. So again, that's why I kind of dabbled in like the nurse navigating sort of stuff, but also on the outside, have thought about getting into like the cosmetic sort of industry. However, people have also like just chatting with people and their experiences, and it's very people like pleasing, or it's what they want, and if you don't do what they want, then why, you know, like, and they're paying for treatments and stuff, but I know it's very competitive as well, which I have found even looking into things like the courses and stuff. I feel like a lot of people like gatekeeping. It's slowly like a bit less of gatekeeping these days. Like I don't know, just trying to talk to people that I know that are sort of into it, and sign up to free webinars online with a doctor and a nurse who like work together and what it may look like. But also for me, of choosing somewhere to train in, if it's the path that I want to go down, it's just what am I going to get the most out of. There's courses from 2 days, 7 days, 2 weeks to a year. So just trying to choose what. I'm pretty sure like the more, like the 12 months ones, you're more diploma sort of situation. But yeah, the 2 days, like facial anatomy, that doesn't come to you overnight. And it's obviously very high risk. People can go blind if you're not injecting in the right, you know, areas. So I'm after a place that would, you know, be thorough, but also kind of not take a year. But you know, I don't know. I'm trying to find something in between. But again, a little bit self-limiting. I feel like if you don't have somewhere, or like someone's not going to onboard you because you don't have experience these days, like laser clinics or, you know, those sorts of places, it's like minimum 12 months experience, which how do you get experience if you don't get hired? And that's a situation everywhere. So it's just unfortunate for that. I would even do like, shadow someone like one day a week or something, just
See
to
what it's
learn.
like. A bit of work
Yeah.
experience.
Yeah, especially if
Yeah.
you're not sold on it,
Yeah.
and you want to see what it's like first. You don't want to do a full year and pay for a course. I don't
Yeah.
imagine it's cheap.
Yeah, like
and-
again, like
Yeah.
like you're saying, it's setting up like. I've found with some places that do the course, they can also like be your prescriber, and they do you can buy the products and everything through them. However, you have to have an ABN, you have to have your FSPOS machine, you have to have a business name. Like I'm like, I don't even know if I
If
want to
you wanna
invest
go.
fully in this
Yeah.
first.
Yeah.
And it's expensive. You have to invest so much time, ongoing learning, because everything's like changing, So yeah, it's in the
You
background.
have to be like
Yeah, you have
fully
to be
invested.
sold.
Yeah. Yeah, and like you said earlier, you sound like you kind of sit more within that system of being able to follow your patients
Yeah.
and have that bit more compassionate side of the nursing. But I mean, it'll be interesting to see where you land. It sounds like you're
Yeah.
already reaching out and doing some exciting opportunities through your nurse nabbing and your discharge
Yeah.
coordinator sort of roles, and sounds like there's lots of opportunities coming your way. And of course, you're very apt, and you've got all the personality skills to get yourself there.
Wait and see kind of what happens.
Mm.
But I can tell you that burnout is happening fast. So yeah, I am actively looking for other things, and just like I want to incorporate, like you're saying, like the patient follow-up and that sort of thing, as well as my clinical skills. Like I really value clinical skills, and I'm proud of what I can do, and I don't want to lose that. I'm only young. I've only been in the industry for 5.5 years. Like I've got a whole lifetime to go of work. So I'm not ready to lose those skills just yet. But where it will take me, I don't know.
Thought we could end on a little, maybe to give some students or people looking at new people advice when you're sitting there at that interview table and they just chuck you that random question and you have to think of a scenario. So I'm going to chuck you one right now. So when has there been a situation where there's been conflict that's arisen, and how have you dealt with it?
Conflict, not my strong point. Observed people deal with conflict, and I know how not to deal with it. Hear what the patient has to say. So let's say it's a patient scenario. Just hear them out and agree with them. Like, I'm sorry for, that this is happening to you. It's hospital protocol. I can escalate this further to my team leader, my manager, compliment complaint form, and they can have their own say, because sometimes as the nurse, it's not your fault, and it's just probably like the way the healthcare system is, or the procedure policy that we follow. Change doesn't really happen if you don't say something about it.
So reasonable, and I think it's a question that gets asked at a lot of interview panels, and I don't think there's any wrong way to answer it apart from, just tell them to get stuffed or something. But there's heaps of approaches, and whether it is that you escalate to a manager, I think validating how someone feels and active listening is pretty much step number one. But it depends if you're talking to a patient and that's sort of the conflict that you're experiencing, and versus a colleague and a staff member, how that looks a little bit different. Even sometimes conflict with your line manager and how you approach that, and there's obviously the hierarchy, balance, and having the self-confidence and the belief to speak up for yourself in whatever situation it is. But hard thing to do, and like you say, it's not comfortable.
Definitely not comfortable. And like, I'm such a people pleaser, so especially in the workplace, I don't try to make conflict. Like I just kind of avoid it at all costs. Like I listen, and I'm just like, and honesty is key.
Well, thank you so much for joining us for our first interviewed episode. We really appreciate it. We hope you guys got something out of our chat with Chloe, a little bit of an insight into some different roles within surgical field and outside the ward and different stuff that's happening. So we'll join you guys next time. Thank you.
Thank you.
Bye, sisters.
Hey, sister.